Okay guys, welcome to your handy dandy Zoll. So first off, you want to make sure that you have Zoll pads and that you want to place them on the patient just like they show here, what I call the sandwich position. So one electrode is right above the heart and one is right behind it. So that'll ensure the best signal transmission to try to get the patient to pace. So when you get to the Zoll, it's going to be off, of course. So if you turn it on, you get to the manual AED mode. First thing you want to do is you want to get out of that screen by hitting manual mode, and you'll see the basic screen. Now down here, you'll notice the green pacer light lit up. So from here, you can turn it down to off and then down to pacer, and it reboots the machine, and it shows you these two little dials, output and rate. Now if you look over at the screen here, you're going to see that over this MA is what the output is, and then the pace per minute is 86, and that's over on the rate dial. Now the hospital decided that due to pediatrics and adults being on these Zolls, that 86 is what they want to use across the board. Now 86 is not what you have to use. You can adjust it as your, by turning that dial like I'm doing. You can see that it's going down. We can say pace at 70, 60, whatever. Now, if the patient is stable enough, you don't have to rush right into transcutaneous pacing. It is recommended, highly recommended, that you try to sedate the patient a little bit, because it's going to be very uncomfortable for them. They're going to be getting a few milliamps more than this, 0, which we'll talk about in a second, hitting their skin every second or so. So it's very uncomfortable, so you want to try to sedate them as long as time and situation allows. So once you're ready to start trying to pace them, you can start turning up this output dial, and turning up the dial, you see that it's turning up the MA. Now typically you're not going to see much result, if you're going to see a result at all, at up in these 80s to 100s. So we're just going to say we start seeing a result right around 100 here. Pardon me as I reach for something. And you start seeing something like this. You're starting to see a QRS response to those pacer spikes. Now, you're not getting a full, complete 100% response. So what we're going to do is continue to turn up the MAs here to, we'll go to 110. And then we start seeing capture. Now capture happens anytime you get a QRS after a pacer spike. But what we're seeing here is 100% capture. So this is what we want. Now, that's great and all, but what we want to make sure is the patient's actually getting the benefit, i.e. they're getting a blood pressure. So if their blood pressure is improved, or their mental status, or whatever is improved, then you know we're doing the right thing. So once you've achieved capture, 100% capture that is, you also want to give yourself a little bit of a buffer. So at 110 you might want to go up to 115, and that'll allow for the patient to move a little bit, or skin contact to change, or whatever. It only goes up in even numbers, so 116 it is. Again, you want to make sure that you were comforting the patient as best you can with fentanyl or sedatives, and then if they still require transcutaneous pacing for more than a minute or two, they're probably going to be heading off to the ICU for more intervention, preferably the CCU for more pacer work, or the MICU if it's a hypoxia or something that can be fixed relatively quickly. One last note on this: if you are pacing a patient with the Zoll, transcutaneous pacing, you want to be looking at the Zoll screen. The Zoll understands that it's pacing a lot better than the bedside monitor does. The bedside monitor will look like some crazy artifact, weird rhythm. You won't be able to interpret what's going on unless you're looking at the Zoll. Another way to look even more closely at the patient's underlying rhythm is this 4-to-1 button. If you push it, you're going to get the Zoll will pause for 4 beats and show the patient's intrinsic rhythm underneath. You won't see it here because it's not doing anything, but that'll give you a quick little snapshot. One last thing which was pointed out to me, which I never knew: if you turn off the Zoll even though it's not lit up, you can actually force the dial down to that pacer setting, and it opens up and it's ready to go pacing. But I wanted you to see how the green light lit up earlier when you went to the other dial. Okay. Here's one quick add-on tidbit for you guys. Once you get transcutaneous pacing on a patient, I mentioned earlier that you want to make sure you have a pulse response with it. The best place to check for a pulse is the femoral artery, because if you try to check the carotid, you might be feeling chest muscle contractions and not their actual carotid pulse. So again, checking a fem pulse is recommended instead of checking a carotid pulse if you're pacing someone. Okay, thanks. Okay guys, here are the questions for bradycardia. What is the second most commonly used medication to treat symptomatic bradycardia? What is the second most commonly used medication to treat symptomatic bradycardia? Next question. What is the default heart rate on the Zoll when you turn it on to get ready to pace? What is the default heart rate on the Zoll when you turn it on to get ready to pace? Next question, number 3. If the patient is stable enough prior to the initiation of transcutaneous pacing, what should you consider doing? If the patient is stable enough before you start pacing them, what should you consider doing? And last up, what is the best place to check for a pulse if you are transcutaneously pacing someone? What is the best location to check for a pulse if you're transcutaneously pacing someone? Okay, thank you guys.